17 years old presents in emergency room with a dull deep ache after he had a fall while climbing rock and had a fall with outstretched hand. The patient remembers that his wrist was in radial deviation when he fell. The patient complains of discomfort in the wrist region and the side of the thumb with minimal swelling and ecchymosis. You move on to physically examine the patient. There is pain with axial compression of the thumb, and there is tenderness in the stuff box between the first and third dorsal compartment. The suggestive diagnosis would be a scaphoid fracture. A patient is shifted to the radiology department with a X-ray, which is a PA X-ray film of the wrist joint. If the fracture is not seen, the patient should have a PA X-ray in radial deviation and ulnar deviation. These views are used to better define the anatomy of the scaphoid and allow visualization of its margin. Another view, that is clinched wrist with radial and ulnar deviation views, may help to diagnose a scapholunate ligament tear, and that can be a cause of patient pain as well. Anyhow, if the patient all X-rays are negative, further images to diagnose an occult fracture that is not seen in plain film can be done. Historically, if you don't see a fracture on X-ray, you prefer to go on proceed with a bone scan. A bone scan can be negative in the first 3-5 days after a scaphoid fracture. Another modality which has come up is MRI. If there is no fracture evident, you can proceed and go forward with an MRI scan. We routinely use CT scan to evaluate a scaphoid fracture if we see a fracture on the X-ray. This gives us best definition of cortical integrity, fracture pattern, and ability to evaluate the humpback deformity or dorsal intercalated segmental instability patterns. Anyhow, any radial aspect wrist pain can have suspicion of scaphoid fracture, distal radius fracture, radioulnar joint injury, parallelate ligament disruption, or injury to the extensor carpi radialis brevis or longus, as well as FCR tendon or a wrist sprain. As someone has quoted, wrist never sprains. Scaphoid is most frequently injured carpal bone. These injuries commonly happen in young individuals and are misdiagnosed as wrist sprains. This rarely occurs in children as the distal radial physis fails first. Fractures are localized with proximal middle or distal third of the bone. The incidence of avascular necrosis increases. The fractures are located more proximally in the poor vascularized area. Most scaphoid fractures occur at the waist, followed by proximal pole and then distal pole. Orientation of the fracture is also a clue for the stability. The most stable fracture orientation is a horizontal oblique, wherein the axis of the load is perpendicular to the fracture line. The transverse fracture, interestingly, are more unstable. The most unstable has a vertical oblique orientation. Fragments are vulnerable to longitudinal shear forces from the radius. Immobilization is the first step in acute management of non-displaced scaphoid fracture and an option for treating them in more complex situations. The scaphoid fracture which comes up and have delayed presentation after 3 weeks need more aggressive treatment and orthopedic consultation. Waist fractures can be considered for open reduction. However, undisplaced horizontal oblique fracture of the waist have the best chance of successful non-surgical treatment. Though close treatment has less surgical risk, the problem is prolonged immobilization and non-union at stake. Close treatment consists of 6 weeks of a cast, and then after applying a fissure splint. Immobilization of the thumb is not a requirement. Where fractures require normally 8 to 12 weeks of immobilization, while vertical oblique fractures of the waist should be referred to orthopedic surgeon. Close treatment of stable non-displace on the proximal pole can be attempted. However, it requires 12 to 14 weeks of immobilization, and earlier orthopedic intervention is sometimes contemplated. However, if you are competent enough to address by polar approach, a transverse fracture can be managed operatively as well. Incision is made over the center of the tubercle of the scaphoid. This can be easily palpated with the wrist in full radial deviation. Incision is curved towards the thumb of the distal end. The proximal end of the incision extends along the radial border of FCR. Incision is made in the sheet of FCR and the tendon is retracted to expose the anterior capsule of the scaphoid. The capsule is incised from the tubercle to the tip of the radius. Care should be taken to avoid underlying articular cartilage of the scaphoid. The radiolunate ligament is now divided for adequate exposure of the proximal pole of the scaphoid. After the joint between the scaphoid and trapezium is identified, an incision is made on the joint capsule around the tubercle of the scaphoid to avoid damage to the blood vessels entering the scaphoid. The incision should not be too deep or too proximal. Hemarthrosis is removed, loose fragments are removed, wrist is manipulated to assess the instability of the fracture, and the scaphoid lunate ligament is also examined for possible tear. Fracture is then reduced, occurring the correction of the angular, rotatory, or translation deformity. To maintain the retraction, K-wire may be inserted into the tip of the tubercle, directed towards the apex of the proximal pole. The fracture is then fixed using a guiding jig. If there is a doubt regarding the alignment of the jig, a radiograph should be taken with a K-wire inserted from the guide. Once correct position is achieved, the screw is placed in position. A radiograph can verify placement of the screw and reduction of the fracture. Wrist capsule is closed and the radiolunate ligament is repaired. The capsule over the scaphoid is closed and the soft tissues are sutured. Skin is closed and a bandage is applied. With proper technique, most complications can be avoided. However, adhesions can cause stiffness in the joint, or scar tenderness is a possibility. Nerve damage causing neuroma is also a possibility. Poor screw placement or other technical problems can cause non-union of the fracture.